Afternoon, Mr. Caldwell.
Hello, how are you?
Very well. Pleasure to actually see you in person.
Yeah, it's nice to connect. I was actually in the session you were moderating earlier. That was interesting stuff.
Yeah, our panel did a great job.
I thought so.
All right, we got a few things going on here, huh? Looks like what Elise is on here. Got all kinds of stuff going on. Looks like she already has one put up. I've got one too that I can put up. Got another. I keep playing with my PowerPoints all the time. I don't know if that's a good thing or bad, but kind of how I do it.
Yeah, I like to tinker as well. So I think right at 2, I've got a few things that I need to read off, and then I'll get things to you as quickly as possible so you can have as much time to go through all the content.
Thank you. So somebody's got some problems with the music going from the last session lunch. I'm not sure how to change that.
You may have a couple of windows open, so that window that's playing the music might be open as well as this one. So if you want the music to stop, you may need to close out of the other window.
Maybe they
If
can
that doesn't
try
work, feel free to put it something in the chat. We can figure something out.
It's like that worked. Perfect.
Awesome.
Hi, Tim. Do you want me to go ahead and stop screen sharing and you can pull up your presentation? Can you hear me, Tim? Okay.
I can. I'm going to pull up mine.
Oh, you can't get the music. I see. Somebody's saying.
Do you see the correct one?
Yes.
Perfect. Thank you.
What we are seeing is the presenter view of the slideshow, so we can see the, yep, there you go.
Perfect. That, okay.
Looks great.
Yes, our system reverses it because of what USU did. We got away from our individual ones and went to a university one. Did not help a lot. So
those technology changes can be, well, they can take a little bit of time to get used to, that's for sure.
Right.
All right, it's officially 2 o'clock, so we're going to get things going. Welcome everybody to the 2021 Intermountain Tribal and Rural Opioid Wellness Summit breakout sessions. This session is titled Naloxone Education and Training, Saving Lives, and is presented by Timothy Keady, MS, from Utah State University Extension. I'm your session moderator, Pete Caldwell, and I'm going to be available for everybody in the chat box at any time during the presentation. Before we get started, I have a few brief housekeeping reminders that I need to go over. This breakout session, like all of the other sessions in this summit, is being recorded, and some content may be reproduced or rebroadcasted at a later time. So if for any reason you wish to remain anonymous during the recording, you can please take the following actions now. I'm going to put some instructions in the chat box. So you can click on the three dots in the upper right-hand corner of your participant panel, and you can choose change profile name and edit your name. And then lastly, you can make sure that your video is off by clicking the video icon in the bottom left corner of your screen. If your video is off, there will be a red diagonal line through the icon. If you need any assistance with this process, you can message me directly in the chat box by opening the drop-down list and typing in Pete Caldwell. That'll send me a direct message and we can get things sorted out for you. To ask a question, please either use the raise your hand function, which is found in your participant panel at the bottom of your screen, or you can type your question in the chat box. All participants will be automatically muted throughout the presentation, but I can turn your mic on if you have a question. And if I remember correctly, we're going to be saving all questions for the end of the presentation. So if you have a question, feel free to ask it in the chat box at any time, and we'll get to it at the end there. So now I'd like to introduce our featured guest for this breakout session, Tim Keady. Tim is a member of the USU Extension initiative called HEART. The HEART, which stands for Health Extension Assessment, Research, and Teaching Initiative team, was created to help battle the opioid crisis in Utah. The team focuses on stigma and harm reduction, prevention and education, strengthening community ties, and resilience building. The HEART team was created with the assistance of Dr. Sandra Sulzer, a USU assistant professor and director of the Office of Health Equity and Community Engagement in Salt Lake City. The OHECE is an office of professionals and health volunteers coordinating tribal, rural, and other wellness outreach initiatives. Tim is proud to be a contributing team member of the office. As a faculty member of the USU Extension, Tim uses his unique knowledge, skills, and abilities to help increase the well-being of the population of Cache and Box Elder counties and all of Utah. Tim provides experience in chronic disorders, education, and management, including substance misuse and suicide prevention, critical incident management and response, public health, emergency medical services, mental and physical health counseling, bias and stigma awareness, risk reduction, promoting positive adult and youth behaviors, and harm reduction. His goal is to create a healthier Utah. Tim, thank you for joining us. The time is yours.
Okay, thank you very much, Pete. We appreciate that. Also want to introduce Odalise Dial. She's a team member and she'll help with our Zoom also with some of the questions we're going to add. Her and Pete, I'm sure, will work together. So I appreciate that introduction. Of course, our bios get very long sometimes, and you can tell I'm a little bit older, so I've been around for a while. So I've done lots of different things. So I've really enjoyed what we've done so far here at Utah State. So we're going to look at some of the things that we can do to reduce some of those deaths that we're seeing from opioid use. So obviously we have our agenda here. Just talk about Zoom. We've done that pretty well. We are going to have a survey as we begin. Then we're going to talk about naloxone basics. Why do we need the training? More information on training, some discussion, and then post-training survey. So we appreciate you being willing to do these surveys for us. Obviously, gives us good information. It helps us see how we're doing as we go forward with this process. So the pre-training survey is here. Hopefully someone's going to put it in the chat for you. Answer the questions to the best of your ability. Even if you're not sure of the answer, your answers will be kept confidential. So please just take a couple of minutes to do that. It's a pretty short, brief survey.
I'm working on getting that in the chat. Oh, never mind. My apologies.
Thanks. I wonder if I should have had a little, like countdown, like a Final Jeopardy kind of thing. Okay. Well, I hope you've had a chance to work on that for a moment. Maybe one more moment, and then we're going to go to the next slide. We're going to talk a little bit about opioids. Opioids are a class of drugs. They're commonly used to relieve pain. Obviously, many people know that. We've talked about that quite a bit here. Obviously, you can see the painkillers done by prescription. A lot of codeines, lots of Vicodin, all those kind of things. Tylenol 3 with codeine. Those are things that we see quite regularly. One of the things that we don't see often, but we see it often, obviously, in prevention, is illicit drugs. People using heroin, opium, fentanyl-laced drugs is something that has gotten worse as we've gone throughout the last 10 years. I spent approximately 30 years in EMS. And so I've seen and done lots of different things in regards to response to people with many overdoses. And towards the end of my career, we actually saw a lot more fentanyl coming into our community, even back east. And having come out here approximately 3 years ago, we're seeing it increase across the state here and across the country. Something that alarms many of us that are involved with response, whether it's law enforcement, EMS, fire, first responders. It's something that we're really concerned about because we're seeing that death increase. And we'll talk a little bit more about the numbers, but the numbers actually become very difficult for me to look at and see because of what I do, knowing that I have lost people to overdose as well as suicide. But having worked in and seen people die from an overdose, whether it's opioids or whatever it might be, fentanyl, whatever you want to call this, that's causing their death, it becomes very difficult. So we want to try and stem that in some way if we can. When we talk about drugs in general, we'll talk about opioids causing a respiratory depression. That's why they kill. And people use some of these substances, opioids, because it increases feelings of pleasure, warm relaxation, and reduces pain. It's often abused for this purpose. So again, fentanyl-laced drugs, we're finding it across the board. We've got some agencies in southern Utah that stop testing for fentanyl. They just assume it's in everything that they get from someone on the street. So what's naloxone's relationship to opioids? Naloxone is not an opioid. It's an opioid antagonist. You can see that it's a substance that interferes with or inhibits the physiological action of another. Naloxone reverses the effects of opioids. It only works on opioids. So if someone's overdosing, whether it be alcohol, benzodiazepines, stimulants, cocaine, whatever, it's not going to cause any reaction. The way we use it is we don't know what someone may have on board or have taken into their bodies. So someone may have unknowingly used an opioid along with some of these drugs. So we try naloxone and we train people to try naloxone. There are few, if any, side effects from naloxone. So I think as we go through this process and you think about what we're using it for, remember that in some cases, I've worked in hospitals where we've actually tried opioids not knowing what was wrong with the patient. Or I'm sorry, we tried to stop the opioid overdose using naloxone so we did not know what the patient had ingested or injected. So we think it's a good idea to try it, especially if you have some. You're out in the field and someone has overdosed or thinks there's something that's happening. You don't see the signs that you see in the movies, kind of with a needle and those types of things. We still encourage people to try using naloxone. We'll talk more about that as we go through the training a little bit further. I'd also like to say, as we begin this training, this is something that we worked on with Michelle Chapus, as well as Dr. Aaron Madding as part of our Troy group. So naloxone, how does it work? Phase 1, the overdose. See in the overdose, you see these little circles or oblong shapes that actually are representing an opioid. And you see the opioid receptors down here that are blue. You'll see that that opioid attaches to the receptor on the brain. That's what it's doing as it's attaching to these receptors on the brain. It's causing a reaction to the opioid. Now, the opioid obviously can cause breathing to slow and eventually stop, in addition to some of those other signs that we noticed before. So remember, an antagonist is a substance that interferes with or inhibits the physiological action of another. So it reverses this from occurring. We're going to show that now. So this is how it works. Naloxone has a stronger affinity to opioid receptors, basically kicks these opioids off, and the naloxone replaces it on the receptors in the brain. When we get into the name, the mu, all that, different things that are considered more medically enhanced information, that's available. We'll have that information available on links for you if you'd like that. But we find naloxone in other medications, Suboxone, some of the opioid medication-assisted treatment. There's different things that are involved with that. So naloxone is actually a very good medication, and this is what it does. It gets rid of the opioid off of that receptor in the brain, and someone who may be overdosing can actually be revived by this occurring. So we've talked about how we're going to stop it. We've got the medication. We know what's going to happen when we give naloxone. How do we get naloxone into somebody's body? These are some of the things that we are going to look at in just a moment. So the basics, obviously we've got injectable naloxone hydrochloride. We've got a Narcan nasal spray. So this is actually something you can use. It's called an atomizer on top here. That can be used as part of a syringe to create a nasal spray. Narcan is something that's been available for a few years now. That actually makes it much easier. You don't have to assemble anything. It comes already assembled, and you just take it out of its package and use it. We also have other versions of naloxone. Evzio, it's an auto injector, works kind of like an EpiPen. Place it, and it actually walks you through it. It's a really interesting medication and dispensing method. It's a little bit expensive, so it's something we don't see often out in the community, but we're hoping that that's going to come down in price also. And then we have Narcan and a new Cloxido nasal spray, which is pretty exciting. The nasal spray that we're looking at here is going to have approximately 8 milligrams of naloxone in it. Narcan has approximately 4. And because of the increase in fentanyl use and the use of more than one Narcan nasal spray, Cloxido was developed to try and create an opportunity for people to use less of the Narcan nasal spray and have it be a higher dose. Because we talk about naloxone being a very good medication and having few side effects, the idea was to increase that capacity for injecting very easily with a nasal spray. We also have pre-filled syringes or a small bottle that can be used, can be sent or can be put into your body with an IM, so intramuscular injection, inject in the arm, leg, or butt with a large needle, obviously not a vein, and then detachable nasal atomizer, which turns into a nasal spray. So there's a couple different ways to do it, and you'll see it in different ways in the community. Why do we need naloxone training? If you've been participating in this conference and summit so far, you've probably seen some of these charts already. Some of the death rates that we've seen, we thought they were decreasing for a period of time here in Utah. We still saw it increasing across the US. So we had very good outcomes related to some kinds of drug use in Utah, like tobacco, but we've also had higher deaths from opioids than the national average for almost 20 of the past years. So the graph shows kind of the Centers of Disease Control, the CDC, deaths due to opioids, including both prescription and illicit drugs. So death rates from opioids in Utah have decreased for a while in 2016, but now we're starting to see that increase again. Obviously there's some positive change, but still work to be done. So as we go through this kind of process of looking at prescription opioid deaths, we do see these changes occurring across the country, and we're hoping that Utah will continue to have some good results. Okay, having said that, this was to 2019. There's a provisional drug overdose death counts that was put out by the CDC. And we're finding that the death rates and death counts from drug overdose in general have increased significantly. Huge difference from 71,000, which we thought was an incredible number, to some of the provisional numbers that we're having now predicted from basically April to May of this year, so approximately a year, approximately 91,862. Approximately a 30% increase across the US, with approximately 70% involving opioids, and 73% of those involving synthetic opioids like fentanyl and others, etc. So we think of all the deaths that are occurring, all things that are happening for the last year or so. Obviously, this is very concerning for many of us that work in any type of prevention or any type of substance use disorder treatment program. This is just some information showing on this side total emergency department visits and then overdose visits. So as you'll see across this time frame of the pandemic, from January to September, you'll see that the rates of ED visits for overdose deaths did not decrease significantly with the visits as we got to this point in April. See, those numbers stayed higher and actually are continuing to increase, at least at this point. And you'll see that the yellow here is opioids. Opioids has not significantly decreased very much, based even on an emergency department visit. So that's, and heroin's here, and then stimulants are here. So looking at how people are responding to emergencies is becoming very important. Emergency departments don't want to see a lot of death. Obviously, it's a big deal. People in EMS don't want to see a lot of death. So to me, a way that we try and limit that is using education. So we want to talk just really briefly about risk factors for opioid overdose. We want to see what's happening when someone ingests enough of an opioid. Basically, an overdose can happen to anyone. Some factors that make more people likely to overdose include taking other medications, antidepressants, benzos, all that kind of things, Xanax, Prozac. Medications that reduce your central nervous system. So you slow down, your blood pressure, heart rate, all that slows down. Drinking alcohol, again, another major depressive medication. Taking opioids, again, if you're taking a break from them. Talk about people coming out of jail, coming out of treatment. That's something that we're working on in Utah especially, and across the nation, providing naloxone or Narcan to people who are leaving jail systems. Being elderly, people think that the only people that die from opioid overdoses are people who are using something illegally. It may not, it may be a mistake. We used to respond to emergencies where someone had taken, by mistake, too many opioids. They'd gotten them from their son, and someone just took it because they wanted to feel better. They had some illness that was given to them, however it may have gotten to them, and the patients didn't know what had happened. Nobody knew how they'd overdosed. Nobody knew what happened to them. But as we responded to the emergency, we assumed that it may have been an opioid overdose because of the presentation from the patient. So we used Narcan and revived that patient. So it's not just someone who is using it on the street, illicit drugs. It can be just a mistake from a prescription medication. We'll talk about that a little more about how we're trying to change that across the country, but it's something that we should be aware of. People with high dose prescriptions for opioid painkillers from their doc, that's something that does happen quite often. We're starting to see less of that now as prescriptions for opioid painkillers have been reduced. In many cases down to approximately 7 days after a surgery, and providing some other care for pain after significant injuries. People with opioid addictions or other substance use disorders, we know they're at greater risk for having an overdose. The COVID-19 impact, loneliness, stress, resources being diminished, caused greater risk for many of the patients that we work with that are in treatment, and that became very difficult. So we actually ended up bringing people back into our community, taking appropriate COVID-19 restrictions for our patients because they were having difficulty being by themselves. So there are things that we did to try and reduce some of these risks from COVID-19, but we know still it was a big problem for many of our patients. So addressing risks from overdose among people with OUDs, we talk about harm reduction. So some of our other groups, we've talked about what we're doing across our state in southern Utah and tribal areas, trying to do some things that actually educate again and provide services for people who are using drugs. It's an effective approach to addressing addiction and overdose. It really is a practical set of strategies aimed at reducing negative consequences associated with drug use. Obviously avoiding death or getting disease like HIV. Goal of harm reduction to meet people who use drugs where they're at, not necessarily stopping them from using them altogether. And we talk a lot about reducing bias and stigma, using person-first language, and gain knowledge about what's going on for that patient or person. We talk about substance use disorders being a chronic medical condition. I think that's something that's been interesting to me is as I work with people that are in treatment or people that we know that are having some significant issues, is how they refer to themselves. We're trying to get people to use different language. And I saw even throughout our chats and even on some of our conversations we had earlier today, people still refer to a lot of things in a way as such as, you know, clean or dirty, that type of thing. Those are things we're trying to change. And just as an example for some of the terms we're trying to work on are things like, you know, someone to call them an addict, a user, a junkie. We want that person to be known as a person with a substance use disorder or a person who uses substances. Clean and sober, terms we don't want to use any longer. We want to talk about drug-free. There's something that we used to refer to as dope sick. So someone who's suffering from withdrawal. So that's a term we want to use. They're withdrawing from a medication. Drug, a medication or a non-medically used psychoactive substance. So trying to use something a little bit different, increasing knowledge base of what's occurring. A reformed addict becomes a person in recovery. We want to use those terms. And we have even people talk to me, I've been through this for many years, people used to talk about children. So addicted children, addicted babies, children being born, crack babies, all of that. We call that kind of a neonatal abstinence syndrome, someone who actually is born with an addiction. So there's things that we use person-first language for that we think is more appropriate and helps relieve some of that bias and stigma that they may feel themselves, but we know that others feel for them at times. So again, I have people that we know that have actually been through treatment many years ago, and still their family has not spoken to them about what happened to them and what occurred even in a treatment process, because there was that much kind of harm that occurred among them and among their families. And it's difficult. We've met people who've been through many treatment programs, you know, cost the family a lot of money, obviously a lot of heartache. So it's really difficult. And I know that by just changing some terms, we hope to address that in some ways to help everyone feel better about who they are and who they're working with and who they're living with. So harm reduction, myth versus fact. One of the myths we've heard a lot when we started doing this, and what we've seen in communities even, is people talk about if you give out naloxone, people are going to use more drugs, have Narcan parties, where they intentionally overdose and revive each other. Okay, obviously that doesn't occur. There's no evidence from scientific studies that harm reduction approaches like naloxone increase addiction or risky drug use. And if any of you have ever been through a withdrawal from a medication, or especially from an opioid, it is not fun. It's actually very difficult. It actually can take days up to weeks to withdraw from a medication or to change that medication even. And I've been through a number of times myself with some injuries that I had and surgeries that I've had. It's a terrible situation to go through, and no one wants to do that. So to do it purposefully, that's just not going to happen. So in fact, people who are addicted to opioids and were trained how to use naloxone are more likely to know how to reduce their own risk for overdose. So obviously they're much less likely to die from an overdose and slightly more likely to enroll in a treatment program than people who did not get naloxone training. So that is a big myth. It's not something that's going to happen in a community, but it's something we want people to be aware of, because we know we hear about that. All these supposed parties that happen. It does not happen. So second myth is if we give out naloxone in our community, people will become addicted to drugs and more people will overdose. So more people will become addicted, more will overdose. Obviously, that's not true. It's know that research shows that addiction and overdose rates do not go up when naloxone is given out. What we do see and what we hear from people when we talk about this is patients with severe addictions may experience more overdoses than they otherwise would, simply because they're alive. That's a problem. We want people to be alive to get treatment. Many people that go through a revival, being revived by Narcan, naloxone, whatever it may be, will in many cases seek treatment if it's offered to them. They're more likely, obviously, to be alive because they didn't overdose and die. And I think that's something that becomes interesting to me, having been in EMS and had people that I know say, well, gee, we kept them alive, it's just going to happen again. And yet the reality is someone who quits smoking is allowed to try and get rid of that addiction multiple times. For smoking, it was somewhere around 9 to 10 times people have to attempt quitting smoking before it actually works. So if we talk about something like an addiction to a significant medication with severe consequences, up to and including death, we need to give that person the opportunity to be revived and get treatment. So when there's an overall rise in addiction, it has nothing to do with access to naloxone. It has to do with many social factors and societal factors that fuel addiction, including prescribing from doctors, poverty, and mental health issues, which is something we've talked a little bit about already in this conference. That becomes a big issue. There's a lot of co-occurring mental health issues with people misusing drugs. So we talk about overdoses costing a significant portion of first responder time and resources. I know that fatal overdoses are extremely costly and traumatize our communities and are a greater harm to society. So we really do want to keep people alive. We want them to seek treatment. And whether that's after one time they get revived or another, to me, that's not that important. We want them to seek treatment and they've got to be alive. And having worked with patients that were revived, you know, that's pretty amazing to have someone thank you for providing the medication that allowed them to live. And I think that's something we also don't think about, is people that actually are being revived are some of the strongest proponents for prevention that we have. We talk about peer education, whatever it might be. I know my colleague, Dr. Voss, is speaking about that in our other section. But peer support is important with people who misuse and use drugs. They're great people to have on your side as coalition members, or even people working with you doing stuff like this. It becomes important to have their input and use their information to help us do this better and provide better treatment for everyone. So we're going to go to naloxone training, building kind of your overdose response skill set. What are some things you can do? You'll see here, there's someone just is injecting into a pad, trying to get used to doing that. Sometimes it's difficult to train someone to actually do that. So there are ways to train people so that they are able to do that injection. It's not easy. It does take a little bit of time, but on the other hand, it's not difficult. People do it with EpiPens, do it with other ways. of injection. So it's something you have to get used to doing. So how do we identify an overdose from opioids? Okay. Symptoms: pinpoint pupils, being unconscious, unable to rouse them, no breathing or only light or infrequent breathing, less than 12 breaths per minute. If they don't respond, we talk about shaking them. So if we do in CPR, shake them, do a sternal rub. A sternal rub is essentially taking your fist and rubbing against their sternum as hard as you can. There's very few people that can not respond to that if they're able to. If they don't respond, obviously there's a significant problem. What we're going to do is talk about what we're going to show what happens a little bit just in some videos, but overdose with opioid drug causes sedation, so sleepiness, low blood pressure, slowed heart rate, slowed breathing, pinpoint pupils. That's where black centers of the eyes become smaller than normal. Others can be skin, cold and clammy. The nails and lips are blue. It's called cyanosis. However, if other drugs are taken at the same time, they may counteract this effect on the pupils and also cause some difficulties in recognizing whether it's an overdose. We're really concerned with that overdose from opioids causing a patient to stop breathing. So we look at our time, maybe have enough time, but we do have an injectable naloxone video that we have here. We're not going to show the real overdose. I don't show that to my people we work with, but the video below shows instructions. I don't know if it'll work if we try it, but maybe let's give it a shot, see if it works.
Hi, I'm Allison, a pharmacist, and today I'd like to go over how to use your naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in the event that you witness an opioid overdose. So you've called 911 and grabbed your naloxone. Now what? Injectable naloxone comes in a 1 milliliter single dose vial similar to this one, and it can be given intramuscularly in the patient's deltoid on their upper arm, their quadriceps on the outer aspect of their thigh, or their gluteal muscle on the upper portion of their backside. To prepare a dose, we'll first remove the plastic cap from the vial and grab your needle and syringe. Now, since we're injecting this medication, we want to try and keep the rubber cap and the tip of the needle clean, so avoid touching those as you prepare your dose. Remove the cap from your needle and insert it into the rubber stopper. Now you'll withdraw the full contents of the vial. There should be at least 1 milliliter of fluid and maybe slightly more due to overfill. But withdraw the full contents. Now we'll get rid of any bubbles by sharply tapping the syringe and removing any air so that we're left with 1 milliliter of liquid. Now your dose is ready for administration. Today I'll demonstrate how to give a dose of injectable naloxone in a patient's deltoid muscle. When giving an intramuscular injection, you'll first remove the patient's clothing to expose the skin. Feel for the bony edge of the patient's shoulder. Place 2 fingers beneath that, and the triangular area here is the deltoid muscle, and that's where you'll be giving the injection. If available, clean the area with an alcohol swab. Then, pinch the muscle to form a firm surface. Insert the needle at a 90-degree angle and inject the dose of medication. Remove the needle and dispose of it properly. Do not recap your needle. Now that the dose has been given, the patient should start to respond within 3 to 5 minutes. However, if they're not responding, it is safe to give a second dose of naloxone in an alternate injection site if you have another dose available. For more specific questions on how to locate an intramuscular injection site or how to choose the correct size needle, feel free to check in with your pharmacist or doctor, and that's how you give a dose of injectable naloxone.
Okay, I hope everyone was able to see that. If you have any questions about what occurred with that, we can also talk about those in a moment at the end. But we also have the ways that we use nasal spray. So the Narcan nasal spray, which is just a little bit quicker. So we can see if that comes up for you guys. You can see that. And we'll show that for a moment also, just to give the other side of that. So injectable as well as nasal.
On average, 115 Americans die every day from an opioid overdose. Knowing how to properly use Narcan could save a life. If you find someone unresponsive and suspect that they're suffering from an opioid overdose, call 911 immediately. While waiting for emergency personnel, administer Narcan. Step 1. Tilt the person's head back. Step 2. Peel back the package to remove the nasal spray. Step 3. Hold the nasal spray with your thumb at the bottom of the plunger and your second and middle finger on either side of the nostril. Do not press the plunger until you are ready to administer the medication, as this could waste the medication. Step 4. Gently insert the tip of the nozzle in either nostril and press the plunger firmly until the entire dose has been administered. Step 5. Remove the device and place the person in the recovery position. Turn the person on their side, and if possible, put their hands on their head and their upper leg forward. Continue to monitor their symptoms. If they do not regain consciousness, administer another dose of Narcan in the other nostril.
Okay, so we've just watched both of those. If you want to use these and you have the medication, obviously you can choose to do either. We know that there's people that provide both in different community members, groups, as well as Department of Health across the nation, and other people we work with, for example, Utah Naloxone. So steps, again, just to reiterate what we do for responding to an overdose with nasal naloxone. Call 911 immediately. Perform rescue breathing, which is 1 breath every 5 seconds. Again, head tilt, chin lift, those types of things you've learned in CPR. Prepare your naloxone, give it to the person who's overdosing. If there's no breathing or breathing continues to be shallow, perform rescue breathing continually. If there's no change in 2 to 5 minutes, administer another dose and continue to breathe for them. You must leave them for only a minute, put them in recovery position. We also talk about, as we do this with patients, putting them on their side, if we can, and continue to kind of rouse them, trying to wake them, trying to get them come back. We don't recommend putting them in a shower, shower them with ice, whatever it might be. We don't do those types of things. We want to just use kind of a gentle shake, maybe a sternum rub, to see if we can get that person to respond. If they don't respond at 2 to 5 minutes, usually say 2 to 3 minutes, we might give them another dose of Narcan. Again, it's not going to cause any problems for them if you give them more Narcan, and it may be able to get them out of that overdose, especially if they have fentanyl in their bloodstream. Okay. Try and wake them up. It's kind of just a way to look at it again. Wake them up, sternum rub, call 911. You do it before or after. We want you to call 911 though if you can. Someone's overdosed, someone's in breathing. Administer your naloxone, do the injectable, check for breathing again, stay with the person, see if they recover. Recovery position, right? Head tilt, making sure that their head's in a position where they can still breathe, hands supporting the head, knee stops body from rolling onto stomach. All right, well, I get in trouble for calling for help during an overdose. I know we've got people from other states on this presentation also. But we know that in Utah, we have Good Samaritan laws. So people call 911. There's some immunity from arrest or prosecution for drug possession for an overdose, but does not protect people who report overdoses from probation or parole violations. That's one of the things I've heard. We've actually had situations where we've had patients revive someone, or someone in their room was revived, and they asked, why were they still arrested? And again, we're going to protect the people who are providing that care, but only to a level that is allowed by law. And some people, we've had police officers who've thanked them and not even asked them for their names. We have other people who've said, you know, checked them and found they had something in their background from parole or something that occurred, they needed to be brought back in and spoken to. But in any case, they were still able to save a life. And I think that's a pretty big deal to be able to do that. We talk about, where can I get naloxone? We get that question a lot. You can get it from pharmacies in Utah. There's a Utah statewide standing order, so no individual prescription is needed. That allows for you to get it from a pharmacy. IHS, Intermountain Health Services in Utah, tribal health facility pharmacies, commercial pharmacies, the Walgreens, CVS, Walmart, all of those. Those pharmacies will have it. Whether or not you have to pay is a question. It's based on your insurance. So you may want to ask them what the cost would be. Locally, we asked for costs, and the costs range from approximately $100 to $135 to $145 for Narcan, for a 2-dose kit. So it is variable, depends on what your insurance would be and what actually is being provided in the community. But we do have places like Utah Naloxone and also Department of Health who can provide it for a minimal cost, if not for no cost. And I think that's important to try and get it to people that need it. We carry it in our office here in cash. In the USU Extension office here, I have some that I provide to the community. But much of what we've had came from Department of Health, from some grants. So we're working on getting more grants to have it available for everyone. So you'll see that many states have similar standing orders for naloxone. In some states, and actually it's being recommended and asked to be done across the country, is co-prescribing naloxone for people who are getting prescriptions for opioids, especially if they're high-risk patients. So if you are taking opioids or get an opioid, make sure you talk to your physician about possibly getting a prescription for it and thinking about filling that if it's a lower cost, or seeking care from someone who can help you get that. Important naloxone facts to remember. Naloxone is safe and has no major side effects. It will bring a person into active opioid withdrawal though, which may mean vomiting, irritability, and other symptoms are fatal, okay? What we find at times is people wake up and they've been revived and they have police officers over them or EMS providers. And imagine waking up from a big, deep sleep even. You wake up and there's people in front of you that you don't know. I say take that and multiply it times 1,000. Someone who's being revived, who has generally used a drug that maybe they knew or didn't know was going to cause that. You've got all these people in front of you that you don't know. So I recommend to anybody, if you can, and you do have someone you think may have overdosed, or you know they've overdosed, having someone in front of them that they know helps reassure them and make sure that they don't respond in a way that may be unusual or unpredictable. We know naloxone only works for 30 to 90 minutes, and some opioids last longer, which means people can re-overdose. So we want to make sure they get some help and not just let them walk away if possible. Because again, remember, fentanyl, again, can be in their system and they can revive and go back into overdose and die again. So it's very difficult if they don't get care. So we do recommend that everyone calls 911 or go to a hospital after an overdose. Whether you're driven there, whatever, we want that to occur if we can see it happen. Again, facts to remember. Naloxone is not an opioid. It's a medicine that reverses the effects of opioids. It only works on opioids, but because many people use multiple drugs, whether it's some kind of a benzo or some kind of stimulant, whatever it might be, the opioid that's in their system will cause them not to breathe. So being able to use that may still help that patient. So we still want you to use it if possible. It's a safe medication. It's used since 1971. We're talking about naloxone, used for many years in EMS before it was available to the community to use as naloxone or Narcan sprays, whatever it might be. Naloxone saves lives. We know that. That's something I've seen. I've been part of that. And having been a person who remembers everyone who's died that we were not able to save, that's very important to me and to many other of us in EMS and also in our communities that we work with here. I think we've got many people from our community that really want to help others. Just like we learned CPR, just like we learned how to respond to a poisoning, whatever we're doing, responding to someone who may have had an overdose is just as important. And providing that naloxone, whether it's injectable, whatever it might be, nasal spray, the new one, the old ones, whatever you can find, that's something that we want you to have on board in your backpack, in your briefcase, in your office, wherever it may be. We encourage you to get it. And someone who may have family members, loved ones, people who may use drugs. We talk about harm reduction. This is a harm reduction kind of thing. We want you to carry naloxone to help others that may need that help. I believe that's very important for us and for our community. And having seen many people who just completely changed their lives after having been revived, it's really, to me, it's very important that we do this. We had patients that were able to revive another person. So this person was at a party, had just been trained by me how to use naloxone, how to use a Narcan nasal spray, and someone at the party went unconscious. And they said, oh, it's an overdose. Everybody started freaking out. And this person walked up and said, I think I can help. Took out the nasal spray, undid it, followed the procedures that we taught him to do, and put the nasal spray up the person's nose, used both of them. And about 3 to 4 minutes later, the person was revived and able to talk, and they were able to get that person some more care and survive the incident. And the thing that was interesting to me, and which was really kind of amazing, was to have that patient talk to others and people in his group and say that by being able to save a life, you know, he felt like something. He wasn't just a drug addict. He wasn't just someone who was worthless. He knew he had value. And to me, we had a counselor who said to me, you know, we saved 2 lives that day by just that occurring. So I think that becomes important. That's what I always think about when I do this now is saving more than one life. We've saved people in many other areas with medicine and things we can do. This allows someone who is out in the community, maybe lives in that community, to save someone else, and that's pretty powerful. So I think if you have any discussions or questions, we can talk about a few things, then we'll have a final post-training survey. And that will be it. We're pretty close. Anybody have any questions?
We haven't had any questions from the chat so far. I'll scan and see if anybody's raising their hand. But if anybody has any, please feel free to post them in the chat or raise your hand and we'll make sure you can unmute yourself.
Okay, well, as long as we don't have anybody right there yet, we'll go to the post-survey training. Post-training survey, I should say. That's here. Talk about how we're doing. Answer questions the best of your ability again. Again, your answers will be kept confidential. Well, Delise may be able to put that in for us, or Pete has, I'm not sure, but we know that someone's going to do it for us. I do thank those of you who've come to listen. Hopefully we gave you some good information. If you'd like more information, please let me know. Be glad to speak with you more about it. I think this is something that's pretty amazing to be able to do this as a community, helping others and provide this to people who need it. It's pretty amazing to me.
Absolutely, well said. Thank you, Tim, for sharing your expertise and your time with us here today. Thanks everybody for attending the session. We are very appreciative that you would join the Naloxone Education and Training Saving Lives breakout session, which was brought to you today by the Utah Department of Human Services, Division of Substance Abuse and Mental Health, the Rural Health Association of Utah, Utah State University, USU Emma Eccles Jones College of Education and Human Services Department of Kinesiology and Health Sciences, USU College of Humanities and Social Sciences, USU Extension, and SAMHSA. We'd love to see how you're participating and practicing the concepts that you've learned today throughout the sessions. So if you're willing to share, you can share how you're doing it using the hashtags that I've just put in the chat box so everybody can kind of connect and see what's going on in all different ways. I think the remaining room is still available for anybody for any general summit questions or any help that with any problems that they've run into throughout the course of the day today. I'm going to put the link to the main room in the chat box for everybody to see. Tomorrow, our main sessions include building a recovery-ready community, the Indigenous Prevention, Treatment and Recovery Panel, a special project presentation entitled In the Stigma, sharing stories of opioid use disorder and harm reduction in Utah, and informative breakout sessions will be held in the afternoon. Make sure that you're logging into the webinar at 9 a.m. or a little bit before. They started really prompt this morning, so if you want to catch everything, make sure you're there right at 9. Thanks everybody again for participating, and we'll see you tomorrow.
Hey, thank you very much, Pete. We appreciate your help here.
Happy to do it.
Thank you.
Oh, Tim, I don't know if you can see a question from Margot in the chat there asking if naloxone nasal spray expires.
I did. I sent her a little thing. I said, yes, it does.
Okay, okay.
It usually expires within 2 to 3 years. I know they're talking about changing that, but I tell people if you have something that's expired, it doesn't degrade very quickly. If you've taken care of it, basically store it in a place that's not too hot or too cold. And we advise patients, well, we tell people they can still use it. If you have this, all you have, try it, and it's not going to do any harm. But thank you. And Odalise, thank you for your help too.
No problem.
We'll do this again tomorrow. So much fun.
Yep.
Maybe I'll do better tomorrow. I don't know.
I thought you were great.